Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month online in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with our podcast editor and my co-host, Josh Berezin. Hey, Josh.
Hey, Lisa.
Today, we're going to talk about 3 articles from the journal that have recently been published online. We'll take an inside look at Colleen Barry's open forum piece titled Fentanyl and the Evolving Opioid Epidemic. What strategies should policymakers consider? Next, we're going to discuss an article by Emma Mcginty and colleagues, actually that includes Colleen Barry as a co-author, called Communication Strategies to Counter Stigma and Improve Mental Illness and Substance Use Disorder Policy. And finally, we're going to get to a more traditional research-oriented paper by Ish Bala and Robert Rosenheck called A Change in Perspective, From Dual Diagnosis to Multimorbidity.
So first up, we have Colleen Barry's article on policy, fentanyl, and the opioid epidemic. This is actually based on a paper that was part of a series that was commissioned by the Thomas Scattergood Behavioral Health Foundation and also the Margaret Clark Morgan Foundation.
Yeah, that's a 6-paper series that Psychiatric Services will be publishing shortened versions of these papers, of these policy papers.
Oh.
So I think as you'll see from our summary of this one, that this series delivers very concise, well-researched recommendations around health policy. So let's get started. Since 1999, this is an incredible piece of data. There have been 91 deaths per day from opioid overdose. And despite some policy interventions, the actual mortality rate has not gone down.
Right. And, there are things that have happened. Famous pill mills have been shut down. There's been increased access to medication-assisted treatment. And there's also been some push towards increasing access to addiction specialists, but the actual mortality rate doesn't seem to really be budging. And this column really suggests that the reason is fentanyl. So fentanyl, I think physicians are kind of familiar with fentanyl from residencies or their work in the medical community. But I personally did not understand how powerful of a drug this was until I listened to this great podcast. Everyone should only be listening to this podcast, but if you listen to a second one, the New York Times Daily had one about the opioid epidemic, and they talked about this police officer who had overdosed because he touched the back of a shirt of somebody who had carfentanil, which is a fentanyl byproduct. Mm-hmm. He touched the back of the shirt and he woke up in the emergency room having overdosed from opioids.
Yeah, and so for our listeners who are not physicians, fentanyl is just a remarkably deadly drug.
Right, and one of the reasons that it's such a problem is that it's incredibly potent. It's 50 to 100 times more potent than morphine. Mm-hmm. It's very cheap to produce. And then also, we have a tool to reverse heroin overdoses with naloxone, but naloxone isn't as effective for fentanyl.
In this piece, Barry recommends 6 separate policies, and we wanted to cover these because they're interesting, they're innovative, and really cause you to look at the problem from some different perspectives. So first, this notion of safe drug consumption spaces. These are places where people can use legally and under medical supervision, use drugs, use opiates. And there's some evidence from Vancouver that this approach decreases mortality and public disorder.
And so their second recommendation, or Colleen Barry's second recommendation, is that to use drug checking services. So these are ways that buyers and sellers can see if what they're actually selling has been adulterated, if fentanyl has been added to the product.
Yeah, and that really underlines this problem that people who are using drugs and using opiates may not know if fentanyl's in it and keep themselves safe.
Right.
So third, and this gets to this issue of the differential and actually reduced impact or benefit of naloxone, which sort of in some sense can't keep up with the fentanyl because it's so potent. So she recommends that we consider updated naloxone distribution policies, and this is particularly important with fentanyl overdoses because fentanyl seems to require faster administration and more doses of naloxone. And so specifically, the ideas are to train first responders, give kits to friend and family, and provide legal protections to people who call for help.
The next one is harm reduction-oriented policing. So everything we're talking about here is harm reduction, basically. This fourth recommendation is geared towards policing. And the idea is to divert low-level offenders into health and social services settings. And she points to this study from Seattle where a similar program lowered the odds of being incarcerated by like 87%.
Yeah, and so the notion is in harm reduction, you're trying to mitigate the negative impacts of using as opposed to punishing people for using. And obviously, some of these suggestions are not unique to fentanyl.
Right.
But because of the problems associated with fentanyl, they're sort of the importance of using them is greater because of how vulnerable people are to dying.
Right.
And sort of along those lines, the fifth recommendation is to expand access to evidence-based pharmacologic treatments for substance use. These include methadone, buprenorphine, and naltrexone. And I mean, it's just incredible that we have these approaches, and they really reach very, very few people who are dependent on substances. In the paper, she also suggests to focus on emergency departments and forensic settings for this if we can't do everything at one time.
Right, and she makes this really this interesting point about forensic settings that rely solely on non-pharmacological treatments, which actually might do more harm than good. Because people get released from prison or jail, they have no treatment when they're gone, and then they also don't have any pharmacology helping them, and they don't have any tolerance to the drug. So when they go back and use, and they're using a bigger dose than they're used to, then it's even more deadly. And so the last one is stigma reduction, and emphasizing the risk of fentanyl. And so luckily, in the next paper that we're going to be talking about, we'll be focusing a little bit more on stigma, so we can
pick it up from there.
Sounds good. So next up, we have Emma Mcginty and colleagues on communication strategies to counter stigma and improve mental illness and substance use disorder policy. They start out with sort of some bracing statistics here. Just 42% of Americans said that they would pay an additional $50 a year in taxes to improve mental health services.
That really shows how far we have to go, given how much work needs to be done around this.
Right. It seems like we're going to be fighting an uphill battle until we can do something about numbers like that.
Absolutely.
So this article is it's a review based on a forum of 45 experts that was convened in 2015 at Johns Hopkins that focused on communication strategies to increase support for mental health policies. One of the points of the article is how intertwined support for these policies are with stigma.
Exactly.
And so they're evaluating 5 different communication strategies on how they affect both support for behavioral health policy and also how they affect stigma.
Yeah, and I think what they're trying to do is focus on or identify where research, because they're really trying to be rigorous here and not just kind of what you think, but where research supports how communication strategies affect support for public policy.
Right.
So it's a very nuanced, actually quite dense and synthetic piece that I really recommend everybody read if you're interested in this area. And we're going to try to just pull out some nuggets of how they summarize the key findings.
Yes. We'll do the best we can.
Yes, we will.
as always.
So the first strategy that they describe is the strategy to provide sympathetic narratives or stories that humanize the experience and struggles of individuals with mental illness or substance use disorders, the kind of vignettes and videos that I think we see that really pull at your heartstrings. And the research shows that this is a promising technique for reducing stigma and increasing support for beneficial policies as long as, and this is what's really important, the stories provide contextual information that kind of points directly to policy changes. So, you'd want to know, well, if the policy change you're after is, increasing insurance or increasing access to psychosocial services or dealing with homelessness or whatever, that as long as some of that piece is woven into the stories, it really kind of has this direct impact from the personal story to policy.
So you need to have context for the broader issues, or else these personal stories don't really land in the way that would actually influence. Mm-hmm. Yeah, and one of the reasons is because then what you're doing is you're just reinforcing personal responsibility. If you're only including the narrative without the broader context.
Exactly. So that leads us to the next strategy.
Right, which is one that does not work, which is blaming people for their problems.
Really? How surprising that doesn't work.
Right, but
how often do we do it?
We do it all the time. And I think this is an important point that they're talking about throughout the review, is that the more people ascribe mental illness and substance use problems to personal responsibility, the less likely they are to support policies that help those populations.
Yeah. Which, and by the way, doesn't mean that people don't need to take responsibility and, own their recovery and own their treatment. But this is really about how responsibility for the causes and for someone suffering from mental illness, how it's represented.
Right, and humans have this tendency, which is called this fundamental attribution bias, to overemphasize that personal responsibility and underemphasize the broader contextual environmental issues. And if a group is seen as totally responsible for a problem, they're much less likely to get support for policies that will benefit that group.
And as they point out, and again, supported by research, when the public views the cause of the problem as outside of individual control, they are more likely to support beneficial policies. So the third strategy that they highlight, again, these are kind of all related to each other, is that messages highlighting structural barriers to mental illness and substance use disorder can raise support for beneficial policies without increasing stigma. So again, as we already discussed, highlighting structural barriers to treatment such as inadequate insurance coverage, provider shortages, things that really, in some sense, make people with mental illness and substance use disorders victims of a problematic social and political environment. So highlighting those structural barriers can increase support for public policy.
We can all think back to these horrific episodes where there's been a violent event in the world and it's actually influenced public policy that's increased support for these policies for funding or some other way to influence
the delivery of treatment, right? So, I do a lot of work in early psychosis.
Yes.
And if you look at the timeline around the financing of such services, the shooting at Sandy Hook directly preceded a lot of public attention that then led to increased funding through the community mental health block grant.
So it's a perfect example of what they're talking about here, is that focusing in on violence can increase public support for behavioral health policies, but the price you pay for that is increased stigma.
And that is a very, very big price to pay.
This is a real problem.
Yeah.
That
We
comes
live
up
it
all
every
time.
day.
Right.
So the question is, what are the implications of that association? So what these authors and this conference want to emphasize is that there are alternative ways to increase the likelihood of support for beneficial policies. For example, like we just talked about, messages highlighting structural barriers to treatment that can produce the desired support for public policies without the price that we pay in stigma.
You don't need to have the trade-off.
Exactly. And yet, what do we do then with these incidents that do occur? There's no easy solution to this, but I think that the point that the authors make is really, really important to keep in mind regarding the choices that we can make when we're trying to craft our own communication strategies.
Right. Which brings us to the last communication strategy, which is talking about treatment effectiveness. So they talk about a couple of studies where people are presented with vignettes about people who are either in treatment and in recovery, mm-hmm. or who are untreated and have active symptoms. So when people are presented with these stories, they have less stigma about people who are in treatment, mm-hmm. And doing well, and they have more stigma about people who are untreated with active symptoms.
Exactly. So this notion of when the message includes active untreated symptoms, stigma goes up. When the message includes the benefits of treatment and how people can get better and do better with treatment, stigma can go down.
Right. Even though you're talking about the exact same person with the exact same disorder.
Yeah. And so it's like, okay, treatment works. But the problem is, as they point out, that even though the messages about effective treatment reduce stigma, it's actually unclear how that message impacts the respondents' views about public policy. Should there be more resources for treatment? Because in some sense, I think, as they point out, the message may have to include information about the gaps in treatment availability, which gets back to the kind of the structural issues and the structural barriers.
Right. So, in summary, to find this kind of money spot where you're increasing support for public policy and you're decreasing stigma, the two strategies that they found to be probably most effective or have the biggest research base are presenting sympathetic narratives with context and in talking about the structural barriers that people face in dealing with these issues. So last up we have Ishbala and Robert Rosenheck's A Change in Perspective from Dual Diagnosis to Multimorbidity. So these authors are making a really convincing argument that we need to shift from thinking about people as having two things going on at once to multiple overlapping problems, which is this new idea of multimorbidity.
Yeah, and they point out in the introduction that years ago it was this big revelation that individuals have more than one diagnosis. I mean, I grew up in the era of, oh my God, co-occurring disorders. People have mental illness and substance use problems, and that pushed us to think differently about the care of our patients.
Seems kind of quaint now.
Yeah, and so what Bala and Rosenheck are doing is saying, okay, no, that was just the beginning.
Right. Yeah, and they also want to put some numbers behind it. So what they did is they looked at VA charts, and specifically they're looking at people with 3 or more specialty psych visits, and then looking to see what diagnoses they had in terms of psychiatric, substance, and medical disorders.
Yeah, so they were looking at people who we all would agree were receiving psychiatric treatment. They picked people who had 3 or more visits in the year.
Right. And they're also looking at a couple of other things, how many different types of psychotropic medications they're taking, socioeconomic measures, and then also some general medical indicators on pain, tobacco use, obesity, and insomnia. They ended up looking at about 850,000 veterans, and I think the results are pretty striking.
I hope they didn't look at all those.
No, they didn't. They looked at. This must have
been an administrative chart review.
They looked at 850,000 veterans charts. Still, the results are nonetheless striking. So the average number of mental and medical diagnoses was 4.6.
That's a lot.
That is a lot.
Per person over the year, right?
Right. It's a lot, but it's not really that surprising for being in clinical practice. I mean, it's a big number, but you can see easily, you can think about kind of your typical patient, and getting to 4.6 isn't that hard.
And we know that these are somewhat older veterans, so we may not find exactly the same number in a group of younger patients,
right?
But still, it's impressive.
Yes, as is the average number of psychotropic prescriptions, which they found was 17.31. And meanwhile, about 2/3 were below the federal poverty level, and about 15% are homeless. 62% had a pain disorder.
That's a remarkable number.
Which one?
To say.
The pain?
The pain disorder. So what this paper really does, very simple paper, it's actually a brief report in the journal, is really provide empirical support for this notion that the authors put forward is we're in a multi-morbidity frame these days, and we have to think beyond co-occurring to multiple morbidity.
Yeah, because that's where our patients are.
Right. And it makes me think about how we can support each other. We, as a community of practitioners, in understanding how to help people manage multimorbidities and how to help our colleagues who are working with us to manage those multimorbidities. And I start to think about, what is even the value of a principal diagnosis?
Right.
Does that in some sense become a distraction from trying to really provide care to the whole patient?
Right. It also just really hammers home this point of kind of being a single, only providing one sort of service, either psychiatric or medical or the social services. You're going to be missing a lot of things. You can't do this by yourself. You really need to have a comprehensive, integrated setting to really address what's going on.
And I think you said the magic word, integration. That's what we really need to be doing in this new world. So that's it for today, Josh. Hope you enjoyed our podcast. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.